Every 90 to 120 minutes, your gut runs something called the migrating motor complex. This is a big sweep that moves all of the debris through your intestines when you're not eating. All sorts of bad stuff can happen when your migrating motor complex is not working. Chief among them is this condition called small intestinal bacterial overgrowth. Hi, I'm Dr. Joyce Knieff. I'm a naturopathic doctor, and I see a lot of digestive concerns, including small intestinal bacterial overgrowth, in my clinic. So the thing here that a lot of people don't realize is that the migrating motor complex activates only when you are in a fasting state, and it activates the most robustly when you are in a fasting state while you are awake. And this is important because anything that you eat does reset the clock on that migrating motor complex. So if you're snacking throughout the day, your migrating motor complex basically doesn't really have a chance. So this is one of the important things that we need to consider for the motility of the gut, especially when you're recovering from small intestinal bacterial overgrowth and you're trying really hard to repair your migrating motor complex, which again, the migrating motor complex can, the damage of the migrating motor complex can be caused by things like food poisoning, thyroid issues, viral conditions, stress, and these can be things that eventually lead to the development of small intestinal bacterial overgrowth. So when you get small intestinal bacterial overgrowth treated, you need to help the migrating motor complex recover so that you can keep the small intestinal bacterial overgrowth from coming back round after round, which is a big issue in people who have or develop small intestinal bacterial overgrowth. So the snacking point here is really the thing that gets people, and that not a lot of people are educated about. When you're trying to recover your migrating motor complex, you need to have periods of fasting. And because the migrating motor complex happens roughly around 90 to 120 minutes, the ideal timing between meals should be about 4 hours. Which, this kind of runs contrary to a lot of the blood sugar maintenance narrative and recommendations that people have when nutritionists and other doctors are trying to recommend eating 6 meals a day for blood sugar maintenance and not considering the migrating motor complex. So these are things that really need to be taken into consideration, and this is why the individualization of medicine is so important, because then we can prioritize what a person is dealing with and be able to give recommendations on meal timing a little bit better. If you are interested on more about the migrating motor complex, I cover this in detail in Module 1 and Module 2 of my motility course. Module 1 is out completely for free. It's in the place where you find the things. And Module 2 and 3 will drop April 21st and will be completely available through the Wayfinders Well membership, which is currently still at its founder's rate, which you get to keep forever if you join now. And the rest of the motility course, there are 7 modules in total. The rest of the course will drop in May. So that will cover an entire toolkit, including nervous system work, pharmaceuticals, supplements, and behavioral things, physical therapy, all of these things that you can use to help repair your migrating motor complex or increase your motility in general. Hope this helps, and I'll see you in the next one. There are a bunch of medications that affect stool consistency and stool frequency, but very few of them can be considered true prokinetics. Hi, I'm Dr. Joyce Knieff. I'm a naturopathic doctor, and I see a lot of complex chronic health conditions, including things like IBS and small intestinal bacterial overgrowth. So I took some notes for this one because this is really a bigger topic that I hope to cover in a future course here. But there are generally 4 main groups of medications that help with increasing bowel movement frequency. So there are the true prokinetics, the Secretagogues, something called peripherally acting mu opioid receptor antagonists, also known as PAMARAs, and then there are the actual laxatives. All of these have varying amounts of efficacy and varying amounts of safety data that's associated with them. Some of them can be used long-term, some of them can't be, some of them are habit-forming. So these are all ones that you should talk to your doctor before utilizing. And a lot of the times when we're talking about enhancing motility after small intestinal bacterial overgrowth treatment, what we're looking at is mostly true prokinetics and cholinergics. In the category of true prokinetics, very oftentimes the most popular one we're going to see is Prucalopride. Other motilin receptor agonists like erythromycin or azithromycin or other macrolide antibiotics can also function as prokinetics by stimulating that motilin receptor. But what we see is that motilin receptor can sometimes get fatigued out. And so if you're giving a macrolide antibiotic as a prokinetic agent, that will slowly lose efficacy over time. Like that just is a thing that happens. Prucalopride, on the other hand, doesn't seem to do that. But there's like only 2 doses of Prucalopride that is on the market. One is 1 milligram and then there's 2 milligrams. And Prucalopride works more as a serotonin agonist, where it stimulates the serotonin receptors inside your gut to be able to move the small intestine. And then you have your cholinergics, which like typically right now in the treatment of small intestinal bacterial overgrowth, we consider the ginger and the artichoke as like a partial cholinergic and serotonergic pathway pro-motility agents. So the ginger and the artichoke mostly goes under the true prokinetic and cholinergic category. We do have pharmaceuticals that are cholinergics, but those tend to have a little, those newer medications are better. And then we have secretagogues, which are medications that cause fluid to come more into the inside of the intestines so that distension of the intestine causes this like reflex to squeeze, and that then moves the bowel forward. So Linzess is a classic example of a secretagogue here. We also have Lubiprostone and Tenapanor. And these are all different medications that work to like varying different amounts on functional constipation, usually not so much with like small intestinal bacterial overgrowth and like maintaining the motility with small intestinal bacterial overgrowth. And secretagogues are different from osmotic laxative because the fluid is different. So secretagogue has more of like a cellular action in terms of like the fluid that goes into the intestine, whereas a osmotic laxative will just directly draw water into the intestine and has like that same mechanism of action. This video is getting a little bit long, so I'm not going to cover the Pamoras because those are mostly for like opioid type of constipations. But like the next category here is laxatives, and laxatives are a huge category of medications that don't really address the thing that we want to address in small intestinal bacterial overgrowth. So osmotic laxatives include things like polyethylene glycol, which is Miralax, magnesiums, lactulose, and things like that, which a lot of people seem to gravitate towards in terms of like wanting to improve their motility. But this doesn't actually improve the small intestinal motility. This just improves your stool frequency. There are other stimulant laxatives like biscodyl, senna, sodium picosulfate, and these ones are more dangerous because they are habit forming. These stimulant laxatives, again, are not what we're trying to do in terms of improving motility to prevent small intestinal bacterial overgrowth from coming back. These have to do more with like the spasticity of the colon and less to do with the actual like coordinated ability for the small intestine to move stuff out. So this is a very common trap. Like a stimulant laxative is not a motility agent. Well, it is a motility agent, but it's not a true prokinetic for small intestinal motility. Bulking agents like psyllium, methylcellulose, different types of fiber, these will help motility in general, and they will help your small intestinal bacterial overgrowth, but these are not a first-line treatment for motility. And then stool softeners like Docusate. I think Docusate is pretty useless, honestly. Like it allows water penetration into the stool to like make it easier to pass, but it doesn't really have any effect on motility. So that's a general breakdown of like the different classes of things that help you poop more frequently. But things that help you poop more frequently may not be the same as things that help your small intestine move things through more effectively. I hope that helps. I know this was a little bit all over the place, but I hope this is a topic that we can break up the discussion of in future videos here. Among patients with digestive complaints who underwent breath testing for SIBO, about 34% tested positive. So slower transit consistently predicts higher SIBO prevalence across studies. And when researchers actually measured transit time in constipation patients, there was a 1984 study in gut by Lanfranchi and colleagues that found 2 distinct patterns. Painful constipation averaged about 79 hours of transit time. It's slow, but still kind of within range. But painless constipation averaged about 186 hours. That's nearly 8 days for material to move through the system. At 186 hours, the MMC has no chance. Bacteria that should be getting swept out every 90 minutes to a few hours now has literal days of extra time to settle in and multiply. And constipation doesn't just create those conditions for overgrowth. That overgrowth also makes the constipation worse. And that cycle is what this lecture is about. All the bad things that can come with it. Constipation creates conditions for bacterial overgrowth, but overgrowth doesn't just sit there passively creating gas. It also actively makes constipation worse. And the mechanism of how is methane. Methane gas, which is produced by organisms called methanogens, directly slows intestinal transit. This is what we call IMO, intestinal methanogen overgrowth. There was a meta-analysis that found that patients producing methane were about 3.5 times more likely to have constipation. So the overgrowth produces the gas gas slows the transit further, and slow transit allows for more overgrowth. And this is like a vicious cycle, and each cycle compounds the last cycle. And this is pretty common, especially in like the Western world. Chronic constipation affects between 12 to 19% of adults and reaches about 36% in people over 60. Women are affected about twice as often as men, and a lot of these people are in this loop without even knowing it. If you have small intestinal bacterial overgrowth that keeps relapsing, or if you're going through a detoxification protocol and it's getting really, really stuck and you can't progress forward because you keep experiencing side effects, then motility might be your issue. Hi, I'm Dr. Joyce Knieff. I'm a naturopathic doctor, and I see a lot of complex chronic things in my office, and a lot of them can have to do with like very base system improvements like motility, intestinal motility. So one of the key pieces of improving intestinal motility, which is improving the speed in which things move through your digestive tract, is improving something called the migrating motor complex. The migrating motor complex is this thing that happens roughly every 90 to 120 minutes between your meals. And it really sweeps out and cleans things, not only from like a small intestinal bacterial overgrowth prevention front of sweeping out bacteria, but it also helps the products of detoxification move through your system in a more efficient way so that you don't reabsorb them through enterohepatic recirculation. The entire first half of my motility course just dropped today, so you can access that entire course through the Wayfinder as well membership that is in the link where you find the things. But I cover the entire science of the migrating motor complex, what it is and what it does, and the ways to improve it as well. So in Module 1, which is free for anyone, so you don't have to pay to get Module 1, I cover the SIBO motility connection, motility as a crucial factor of Phase 3 detoxification, and other conditions in which motility has contribution towards, including things like chronic constipation. In Module 2, I cover more of the science, including the serotonin signaling, gut hormones, including motilin, CCK, ghrelin, PYY, and GLP-1. I cover the microbiome motility axis, the impact of your thyroid hormones on motility, stress, cortisol, and the vagus nerve, and the migrating motor complex in a little bit more detail. In Module 3 of this course, I cover more gut-brain connection and stress management, including strategies like vagal toning exercises, breathing techniques, physical movement, and the sleep and circadian rhythm, as well as digestive timing on how to improve your motility from a standpoint in which you are not taking supplements or medications. I go through a lot of recent and studies in the past decade in all of these modules, so all of this is pretty evidence-backed, and I will fold in some of my clinical experience there. I always am very clear about what the evidence says and what it doesn't say and what I've seen work in patient populations. So that entire thing is out right now. I am really excited, and hopefully as I'm continuing to work on the second half of this course, modules 4, 5, 6, and 7 will drop at the end of May as well. So check it out. Thank you. So this is something that I harp on all the time. The short chain fatty acids are so important. And this is part of why SIBO sometimes follows any antibiotic course, not just SIBO-specific treatment. A lot of people can develop SIBO from having taken antibiotics for a lot of different reasons. And the same drugs that sort of clear one bacterial problem can disrupt the motility-supporting bacteria and set up conditions for the next one. So how do bacteria actually maintain the enteric nervous system? This is through specific chemical messengers they produce when they ferment dietary fiber. These are called short-chain fatty acids, or SCFAs. The three main ones are butyrate, propionate, and acetate. Butyrate is the one that matters the most for gut motility, and it's an active signaling molecule that your enteric nervous system responds to, and also provides the primary energy source for the cells lining your colon. The bacterial species that produce these are Roseburia or Faecalibacterium prausnitzii. Faecalibacterium prausnitzii. It gets me. It's a really long name. But when these species are abundant and well fed, they produce butyrate that supports your gut nerve structure and helps your enterochromaffin cells make serotonin. If you lose them through antibiotics or through a low fiber diet or a low fermentable diet, or just SIBO disrupting the microbiome in general, that butyrate production can drop and the motility tends to go with it. The butyrate picture here has some amount of nuance as well. A 2024 study in the British Journal of Pharmacology found that butyrate fine-tunes how serotonin is handled at the receptor level rather than just producing more of it. This is actually more of a sophisticated role than simply raising serotonin levels, and we know that simply raising serotonin levels in the previous lecture that might not actually work in the correct way for motility. So instead of just raising serotonin levels, the butyrate seems like it's calibrating the signaling itself. So remember the SSRI discussion from earlier in this module where we saw that just having more serotonin available doesn't automatically mean better motility? This is kind of the flip side of that. Butyrate appears to be working at the level of receptor sensitivity and transporter function, which is much more targeted than just supporting the motility by flooding the system with serotonin. Transit time itself shapes what producers colonize your gut. So research published in Gut in 2023 showed that faster transit favors bacteria that ferment quickly and produce mainly acetate, whereas slower transit gives butyrate producers more time with complex fibers. Each influences the other in an ongoing feedback loop. So having an adequate amount of transit time really matters here, and it's sort of a chicken or egg thing. There's also one more layer here that connects back to the last lecture as well. Short-chain fatty acids also directly trigger GLP-1 release from L cells in the colon through very specific receptors called FFAR2 and FFAR3. In a 2024 study from the University of Copenhagen, they kind of like confirmed this mechanism. So your gut bacteria aren't just supporting the serotonin motility chain, they also influence the braking hormones that we covered in the last lecture. So in a healthy gut with normal transit, all of this, including your gut hormones, is a completely coordinated system. So when the microbiome is disrupted, you sort of lose regulation on both sides of this simultaneously. Okay, so this is one of the hills that I will absolutely perish on in terms of the treatment of SIBO. Hi, I'm Dr. Joyce Knieff. I am a naturopathic doctor and I treat a lot of complex chronic illness in my practice, with small intestinal bacterial overgrowth being one of them. SIBO is a motility issue. It is a small intestinal motility issue. The reason why the recurrence rate is so high is because when your small intestine does not have proper motility, when it's got dysmotility even, when it isn't moving properly, then the bacteria that you just killed off can grow back way easier. And the answer isn't just to kill it harder every time to make it not go away. And this is also the reason why when there are certain people who have SIBO for the first time, if you kill it off and their motility is mostly intact and their guts mostly recover their motility, then they don't get reoccurrence, versus someone who has had chronic SIBO and had it treated multiple times. If the motility is never addressed, you are going to have reoccurrence. And I think this is important to note that small intestinal motility is different from large intestinal motility. So the bowel regularity that comes from the colon/large intestinal motility is not necessarily reflective of small intestinal motility, because with small intestinal motility, you can have a slow transit through the small intestine, but still have diarrhea from the large intestine. And the hallmark of SIBO is bloating, right? And with that bloating, with the gas of like hydrogen and methane, a lot of times those gases are kind of neurotoxic to the nervous system, the enteric nervous system around the small intestine. So it causes dysmotility. It causes dysmotility, and then that dysmotility, then chicken and eggs with the SIBO, because when your small intestine can't move things through, that's when things are more likely to ferment. That's when things are more likely to produce gas. So a monotherapy like Xifaxan going in and killing the bacteria and then just like leaving it, that has a really high recurrence rate. Even when I learned how to treat SIBO, maybe like about 10 years, like a decade ago now, I learned that after you put people on, and back then it was metronidazole nystatin, back then when you would finish off the course of antibiotics, you would give low-dose erythromycin as a pro-motilic agent to prevent recurrence. Now I use like a combination of ginger and artichoke because that helps the gallbladder, and bile acids are a pro-motility agent. Anyway, you have to address the motility to prevent reoccurrence. Hope this helps. So you can't treat small intestinal bacterial overgrowth without properly addressing the motility of your small intestine. That's just a thing. If you do not address the motility, you are going to get reoccurrence way more likely. So I addressed this in a previous video, and I talked about how I use ginger and artichoke in my practice to try to stimulate the motility of the small intestine for patients in my practice. And people wanted me to go into a little bit more detail, so let's talk about the things that can help with small intestinal motility. One of the simplest supplements that I use is that combination of ginger and artichoke. And this is a supplement. A lot of different brands carry it, but it's basically the same formula. So I use Motility Activator by Integrated Therapeutics in my practice. And I think there is also another one called Motility Pro that is the exact same formula. And then there's like another one done by an enzyme company that is also some sort of like motility thing, except that one has a little bit of apple cider vinegar in it. So all of these are basically the same formula with some variances. I usually choose between Motility Activator and Motility Pro depending on the price, because sometimes one is more expensive than the other, and I go with the cheaper one because they're the exact same thing. But also, here's the thing. What if you do not tolerate ginger? Because this can be another thing that happens where like the ginger is a little bit less tolerable to some people. I will say in Motility Activator, they've done special processing to the ginger to kind of take out the spicy part so that the tolerance to the formula is a little bit better. But in the case that someone is not as tolerant to ginger in particular, there are other ways that you can get around it. So there are also certain formulations that include 5-HTP, which is a serotonin precursor, because serotonin really does also help with the motility of the small intestine. So by boosting the production of like serotonin maybe endogenously in the small intestine, you can also boost motility. You do have to be careful with 5-HTP, and the reason why that's not like really my first choice is because it does also have mood effects, and 5-HTP is a precursor for like not only serotonin, but it can have like effects on melatonin as well. So that it gets a little bit messy in terms of the pathway. So I tend to prefer using ginger and artichoke. And there are several formulas that combine 5-HTP with acetyl L-carnitine for that pro-motility effect. There's also a formula that has been used in the SIBO community for a long time. I believe it's a German formula. It's a little bit harder to get in the United States, or historically it has been. It's called Iberogast, and the key herb in that formula is bitter candy tuft, is Iberis. And it used to be very hard to get in the United States, so a lot of, like, I just haven't gotten into the habit of using it just because Motility Activator does work so well. Recently, though, there's been actually the company of like one of my mentors and my colleagues, called Heron Botanicals. They have started carrying bitter candy tufts, so I've been starting to experiment that with some of my patients who don't tolerate ginger as well. And I will say the mechanism of action in which a lot of these bitter herbs work to sort of get your small intestinal motility back is in part by stimulating bile flow as well, because your bile is it signals your small intestines, which is why I've been kind of like on a bile rant. Like, you cannot just take away your bile. Even if you don't have a gallbladder, your liver will still produce bile and have that drip into your small intestines. And that bile signaling is what causes like coordinated movement through your small intestine. So with bile, there's like several things that go into it, but essentially what it does is when bile hits the first part of your small intestine, it actually puts a brake on the last part of your intestine so that it has this coordinated wave that moves things through your small intestine. And this is especially important when you're in a state of fasting, because there is something called the migrating motor complex, the MMC, that really, really is dysfunctional in people with chronic SIBO. And part of the migrating motor complex, part of its job is moving stuff like trash out of your intestines. Because when you're in the active phase of digesting food, you know, there's a lot of sphincters involved in your digestive system where your body doesn't want to have like big chunks of stuff to, you know, go through your intestines, because you need small chunks to be able to absorb it better, right? But the reason why your dog can swallow a penny and then poop out a penny is because of this migrating motor complex. Like, that happens after your body is mostly out of a digestive state, and it can open the sphincters and move all of the trash through. And this is what also helps bacteria not linger in your small intestine so that it can overgrow there. So yeah, in order to really properly treat your SIBO, your small intestinal bacterial overgrowth, from a root cause perspective, in preventing it from reoccurring, you need to address the motility of the small intestine so your small intestine can continuously move bacteria out so that bacteria doesn't have a chance to overgrow in your small intestine. And so having these pro-motility agents, if not during the antimicrobial treatment of SIBO, then directly after, is really, really important in making sure that we recover that function of the migrating motor complex. So, hope this helps. So here's another thing about motility in the treatment of small intestinal bacterial overgrowth, because in order to keep small intestinal bacterial overgrowth from coming back, you need to have good small intestinal motility. And there are a lot of different reasons why your small intestinal motility would be off. And if you can't address those reasons, a lot of the times the interventions that you employ to treat the motility only are going to work for a little while and not work, or they're just going to not work at all. Hi, I'm Dr. Joyce Knieff. I'm a naturopathic doctor, and I see a lot of complex chronic health conditions, including SIBO. So this is kind of a continuation on the discussion of a question that I've gotten fairly often on my recent videos on what happens if someone has taken a bunch of different types of motility agents and they've all worked for like a little while and then they've stopped working. If I were working with this person in my clinic, I would say that we missed something. Something did not get addressed, which is why the body keeps reverting to that state of stagnated motility. And I'm going to try to make this video brief here, but two things come to mind. One of them, well, three things actually that come directly to mind. One of them is that we have not treated the SIBO completely. There might be biofilms, there might be something going on that is causing the system to feel like it can't like really move forward, or there are bacterial byproducts that's directly impacting the motility of this system. The second one is a little bit more from the neurotransmitter front, from the autonomic nervous system. If this person is under a constant amount of hypervigilance, the rest and digest system is going to get shut down. Does this person need more hands-on therapy to help prime their system to be able to recover that motility and not just focus on taking meds and supplements? The third one is immune system, because when inflammation is high, this can also really affect the gut, especially if you have something autoimmune going on. That's going to really affect the gut function. This is when I would possibly do like a more in-depth workup of certain things, because like if this person hasn't been worked up for like autoimmune gastroparesis or something like that, that needs to be ruled out first. And if this person has a surgical history and has like adhesions and stuff, that's another place in which like hands-on therapy can be really helpful for like scar tissue reorganization and things like that. If this person has a high immune system activation from like mast cell activation syndrome, where there's like a bunch of, I mean, usually with histamine it's diarrhea, but like you never know with like the way that people are going to interact with certain things. And sometimes when there's high inflammation, people can manifest with constipation instead. So I would look into those things and just see whether or not there's something that we missed in this person's treatment that is making it so that their motility is stubbornly not recovering. So yeah, hope that helps. Does celiac disease slow motility? Hi, I'm Dr. Joyce Knieff. I'm a naturopathic doctor, and I see a lot of complex chronic illnesses. Celiac disease and the interplay of celiac disease and small intestinal bacterial overgrowth is a really interesting one to talk about. So the answer is yes, celiac disease does impair small intestinal motility. And this mainly comes from like a intestinal permeability front, because having increased intestinal permeability can also affect motility. So when you have celiac disease, the gliadin in wheat can trigger the release of a chemical called zonulin. That's a thing in your body. And what zonulin does is it makes the tight junction, it like kind of unzips the tight junctions between your intestinal cells. So imagine my hands are intestinal cells with their like little villi on the top. What they can do is just like cause a slight separation there, and this can increase the inflammatory load around the intestines. And in some cases, this can damage the enteric nervous system, which affects the migrating motor complex. And in some studies, they found that this can continue to happen even after someone's been on a gluten-free diet, maybe for up to a year. So the motility impact in celiac disease is pretty profound. There was a 2019 study in the United European Gastroenterology Journal that used MRI to measure the fasting small bowel water content in newly diagnosed celiac disease patients. And so normally the migrating motor complex keeps like the fasting small bowel water down to pretty low by like sweeping it out. And what they found in the study is that the celiac disease patients had roughly double the amount of fasting small bowel water content compared to healthy volunteers. So this is, they also found that the water content in the people with celiac disease was significantly higher than patients with IBS diarrhea as well. Diarrhea prominent to IBS as well. And the interpretation is that the migrating motor complex cleaning cycles are impaired in active celiac disease. So yeah, celiac disease is one of those instances where like the inflammatory load with the increased intestinal permeability is something that directly affects the motility of the small intestine, which can then predispose to small intestinal bacterial overgrowth, which can then like further cause more food issues for people who already have issues with like wheat and gluten. There's a lot that affects motility, but there's a big part of motility that basically predisposes people to have a higher chance of developing small intestinal bacterial overgrowth, and having poor motility makes it so that it's harder to get rid of small intestinal bacterial overgrowth, or makes it so that it's more likely that your small intestinal bacterial overgrowth is going to reoccur after you treat it with antimicrobials. If you're curious about more of this type of stuff, I am doing that motility course right now. The access is just $27. After we get half the course out and have more of a robust course library on our education platform, we are thinking about raising the price, but if you join now, it will be our thank you for you forever. You can keep that rate for life, because we're just trying to get launched here, get some of this information out to people at a rate that is more affordable than hiring a naturopathic functional medicine doctor, aka myself, because I know that I'm not the most affordable to work with one-on-one, and I want to make sure that people have access to this information. So hope this helped.